Hello, everyone, and welcome to tonight's webinar, Pathways and Targets, and How Do These Affect My Treatment Options? So a few housekeeping notes about tonight's webinar. Our speaker tonight is Dr. Gail Eckhardt, and I will introduce her here in just a second. A couple of other things. We do archive all of our webinars, and so if you know of someone who couldn't participate tonight, or you'd like to go back and review some things, you can visit that site that's listed there and see all of the webinars that we have had archived. And there will be a survey that will come to you via email at the end of the presentation, and we would really appreciate it if you take a few minutes and fill that out, and we will get a free Blue Star of Hope pin to you after you complete that survey, so that would be great. And there is a couple ways you can ask a question. You can do so on the panel on the right-hand side of your screen, or you can actually call into the Fight Colorectal Cancer answer line at 877-427-2111. Our disclaimer there, basically just letting you know that the information and the services provided by Fight Colorectal Cancer are just for your general information purposes only. And tonight's webinar is actually part of what Fight Colorectal Cancer calls our monthly patient webinar series. So for the remainder of this year, we're going to continue to have them on the third Wednesday of every month from 8 to 9:30 p.m. And the next one we have coming up is actually very specific, and it's specific as it relates to a side effect from chemotherapy, and that is peripheral neuropathy. So if you have a chance and you can tune in on October 16th, you can go to our homepage, which will be at the end of the presentation. It's fightcolorectalcancer.org, and you can register for either that webinar or another topic we have coming up is advances in surgical treatment for colon and rectal cancer patients, and that one's in November. So my name is Kim Ryan. I am your moderator tonight, but our real star of tonight is Dr. Eckhardt, and it is my pleasure to introduce her to you guys. She is the professor and head of the Division of Medical Oncology at the University of Colorado in Denver, where she also holds the Sept Harlow Endowed Chair for Cancer Research. And after graduating from the University of Texas, Dr. Eckhardt completed her internship and residency at the University of Virginia Medical Center. And after a postdoctoral fellowship at the Scripps Research Foundation, she completed her training in medical oncology at the University of California in San Diego. Dr. Eckhardt has served on numerous committees, including the ASCO Molecular Oncology Task Force, the ASCO Board of Directors, the FDA Oncology Drugs and Advisory Committee, and the NCI Developmental Therapeutics Study Section. She is a member of 2 NCI steering committees, both gastrointestinal and investigational drugs. And Dr. Eckhardt is the principal investigator on 3 NIH grants involving early clinical trials, mentoring, and colorectal cancer research, and has conducted numerous phase 1 and phase 2 clinical trials. Her primary area of interest is in the preclinical and clinical development of combinations of molecularly targeted compounds with a laboratory focus on colorectal cancer. So as you might suspect, she's a very busy person, and we really appreciate her taking some time and sharing her expertise with us tonight. So Dr. Eckhardt, I will turn things over to you both verbally and manually, and give you control of your slides to advance yourself.
All right, thank you. All right, so I've got this little thing here saying show my screen.
That you should be, oh, well. Now, so let me switch it back here.
Okay. Somehow it went away.
Yeah. Hang on, bear with us with our few technicalities here. There we go. How's that?
I think what I may need to do is to log in again. So let me, because I didn't get the screen back. So let me just log in. Okay. All right, so I am seeing the screen. Can you guys, you can still hear me?
Yeah.
Okay. For some reason, I'm not seeing my slides.
Okay. Let's see. How about now?
Yes, I am
Good.
seeing my slides. Thank you.
Okay. You know what? Why don't I go ahead and let's see.
Maybe you should change them. So, well, let me, I'm moving my mouse to see
Yep.
if I'll be
Yep.
able to.
Just give it a second. There you go. You're all set.
Right. So, what I thought I would do tonight is to talk about some of the pathways and targets that have clearly been established in colorectal cancer, with the idea that these are pathways that we now have targeted agents to treat. And I think many of us have been very happy that we now have more biologically targeted drugs for colorectal cancer. And as we've developed them, certainly there have been challenges and lessons learned. And I thought it would be nice to just sort of go through and give you an overview of some of those questions and some of the results. And I think some of the issues with regards to some of the novel targeted agents. And so I always like to start with what have we learned? What are some of the lessons learned? And clearly, what we are learning in colorectal cancer is that we really do need to develop ways for better patient selection. And I think most of you have heard a lot about the EGFR-based antibodies and the fact that having the KRAS mutation really, we now know, is something that really negatively selects a patient for that treatment. One of the very major surprises to us was that we actually thought that we could combine biological agents and actually get better activity. And clearly, many of us wanted to see whether or not by combining biological agents we would actually get less toxicity. And so unfortunately, that has not been the case. We've also found that if we assume that what works in advanced colorectal cancer is going to work in the adjuvant setting, that we really can't make that assumption, that we have to do the proper types of clinical trials. And again, what we have found is that just indiscriminately combining drugs does not lead to better effects. So that always sort of humbles us about what we've learned. Now, if you look here, you know, this is a very common slide that is shown, just giving you an idea about where we have gone in this disease. And it's funny because it definitely ages me. I was involved in the addition of actually the phase 1 trials of irinotecan or Camtazar back in the early 90s. But however, you know, to me that was a really good example of what clinical research can do, because the initial activity of irinotecan in colorectal cancer was really identified in the phase 1 trials. And so we quickly enrolled patients that had received 5-FU and were having lack of benefit onto the phase 1 trial, and many patients had a very nice benefit and actually became very quickly FDA approved. But that sort of process has been going on, and you can see here that we've made some progress. But as you know, I have had clinic today. Clearly, this is not enough, and so I really think where we're headed now is towards the integration of biological treatment with chemotherapy. So angiogenesis, I just wanted to briefly go over this because I also was involved in this area of development very early on. And, I think what we now know is that this process in colorectal cancer is very, very important. And what is really known is that in order for the cancer to grow and spread, that the process of angiogenesis is critical. And this was really spearheaded by Judah Folkman back in the early 70s. Now the question is, how does this relate to colorectal cancer, and what is sort of the actionable item there that we can act upon to really lead to clinical benefit? And again, this is sort of a busy slide, but mainly just making the point that we think it's really mainly controlled by what I think of as a master regulator called VEGF, so vascular endothelial growth factor. And this just gives you a sense of how it is sort of this major switch that leads to this angiogenesis. But really the next question is, well, what does that mean in terms of treatment? And so right now, and again, one of the reasons I think this is a very important pathway is that several different ways of targeting this same pathway have led to clinical benefit. Now again, I think of it as being incremental clinical benefit, but at the end of the day, what we want to do is to be able to put together several different components that can really block the abnormal biology of colorectal cancer. And so we think of this as being one of those very important components. And this slide is really just to talk about the fact that we have, when we think about small molecules, we're talking the pills that basically hit the receptor. Antibodies, you're probably familiar, that's more of a biological agent. And then now we have drugs like aflibercept, which I'll talk about in a minute. But basically what you see is that we're causing blockage both up and down in the pathway. So I'm not going to spend a lot of time trying to go over through all the different trials, but this was a seminal trial that really told us that the combination of adding an angiogenesis inhibitor to what was then sort of the most common regimen of irinotecan and 5-FU was a randomized phase 3 study. And on this slide, these are always a little bit difficult to interpret when you're not looking at it, but we're really looking at the advantage of that top line showing about a 4 to 5 month difference in overall survival. Now, I think for most of us this is like not enough, but these are the types of benefit where we feel like if we're reaching this far, that potentially we can keep adding on. And clearly this was one of the first biological agents that we found to be active in colorectal cancer. So let's see. Sorry. So this next slide is something that I was actually involved with a lot, because as soon as we found that bevacizumab worked, then everyone was really on the bandwagon for trying to find what we call small molecules or pills that will also inhibit this pathway. Unfortunately, and I would say this almost killed the field, was all of these negative trials. And you can see the large number of patients that had to participate in these trials, which essentially came out with no significant clinical benefit. Now, the interesting thing was that these were often combined with chemotherapy. And so we now are a little bit more concerned that when we combine those types of drugs with chemotherapy, that for some reason they just don't work as well as the bevacizumab. And so this is where we got with regorafenib. And so this is one of the new small molecules, so it's oral, and it targets angiogenesis. And really, when you look at it on face value, it's not very different from many of the other drugs that I just showed you. I think really the main difference with this agent was how it was tested, which was given by itself in patients that had already had the other types of chemotherapy. And so here, again, a busy slide, but what we're showing is the types of side effects. And so really one of the main concerns with this drug has been some of the side effects having to do with fatigue and hand-foot syndrome. So we feel like that in some respects there's, some risks of toxicity with this drug. But up until now, we also didn't have what we called a drug that we could use in later stages of disease when patients have really had chemotherapy and it's no longer working. So we feel that it's an incremental progress in terms of a biological agent, but still not where we want to be, and in particular, some concerns about toxicity and quality of life. And so on the next slide, it gives you a sense about overall survival. And, again, what we're looking at is just the difference between the two curves. It was about 42 days. And, those, you can always have different views about that. I tend to look at it as, I think this is evidence that we're making progress, but it tells us that we still have a long way to go. And I think it also tells us that we need to continue to test new targeted agents. Now, another way that you can target this is sort of, again, through a biological approach where you actually have sort of a decoy that is binding various components of the VEGF pathway. And so on the next slide, it shows you a little bit how the different compounds compare. And really the main point of this is just to say that it's distinctly different from bevacizumab. It is a biological like bevacizumab, so it's an IV, but it's a little bit different than the VEGF regorafenib type of drug that is an oral drug. But you can see again that what we're finding is that as we test this pathway and target it in various ways in colorectal cancer, that we've actually made some progress, not enough, but some. And so in this trial, this was basically combining aflibercept with FOLFIRI and comparing that to placebo. And here again, I just always have to show, the side effects, because I think that is something that it's very important in the conversation about making choices of targeted therapies. And here you can see a list of some of the side effects, such as diarrhea, asthenia, which we just mean tiredness and just generally not feeling well, and again, sort of the hand-foot syndrome. And one of the concerns with this agent had to do with treatment discontinuation related to not just disease getting worse, but having side effects. And on the next slide, again, showing the same old curves that we always show, about a 6-week longer overall survival. And one of the concerns with this study has just been that there wasn't a direct comparison to bevacizumab, and so you've probably seen some of the discussions about that controversy. So in terms of angiogenesis inhibitors, I think that they have been firmly set as something that should be integrated as targeted therapy in colorectal cancer. And increasingly we're finding that they can be used at different components during the disease course. And we know that bevacizumab is very easily combined with chemotherapy. And many of you may find that you're not seeing aflibercept used as much. Certainly in our center, it's not used very often. And that really just relates to some of the unfamiliarity that we have with it and some of the concerns about toxicity and not being convinced that it's better than bevacizumab. Now, regorafenib definitely is one that we think is active in refractory patients. Again, we want to improve upon that, and it is in the class of drugs that have not worked as well with chemotherapy. And I guess one of the concerns that many of us in clinical research have is that clearly there are going to be patients that are not interested in participation in a clinical trial, but we definitely want to see that we don't feel that regorafenib or some of these agents are really enough, because we really need to have some blockbuster targeted agents, and that's what many of us are trying to work on. And many of you then have heard about biomarkers. And I just wanted to make a comment about, because you're going to, I think really everyone is going to start hearing a lot about biomarkers and patient selection. And the main type of biomarker that you're going to be most interested in is a predictive biomarker. Now, a prognostic biomarker is one that tells you how you're going to do regardless of what the therapy is. And that's something that you can't really change. A predictive biomarker is going to be something that's going to tell you whether or not you should get a certain treatment or not get a certain treatment. And these are the types of things that I think are going to be much more common with targeted therapies. Now, it's interesting in the angiogenesis field that biomarkers are not useful. And so we think that's related to the fact that we're really, with those drugs, we're not just targeting the tumor, we're also targeting the tumor microenvironment and the blood vessels. And it's much tougher for us to develop biomarkers around the environment, because much of it is going to be pretty much the same from patient to patient. And so what we've been looking at is, should we look at, you know, the development of high blood pressure? We know that that is a physiological biomarker. And so is there a way to use those types of effects of the drugs to really tell us whether or not it's having its best effect in a patient? Now, I wanted to move on to really the other main pathway in colorectal cancer, which again is a targeted agent. There's targeted agents for this pathway. In fact, this pathway is one that's being extensively developed in a lot of different tumors. And you can see here, it's also a master switch. Now, this is more of a master switch that is really related to the tumor itself. So it's essentially a switch that turns on the cancer cell. It tells it to divide. It actually also tells it to stimulate blood vessel growth, and often tells the cell to live even when it's programmed to die in the face of chemotherapy. So we think of this EGFR, epidermal growth factor pathway, as being one that is a survival promoting pathway. And so therefore, for years, it was thought to be very relevant to target in colorectal cancer. Again, just sort of talking about the seminal study, which was adding this drug to irinotecan, again, showing an advantage in terms of time to progression. So very early on, in fact, this was kind of interesting because they were able to show this even in the preclinical studies in mice, that if you took tumors that were resistant to irinotecan and now added cetuximab, that you got resensitization back to the chemotherapy. So what about biomarkers for EGFR antibodies? Just a little bit of history here. Early on, the idea was, well, you know, I think in order to target this, then you have to have expression of that protein on the tumor. And really what we've been learning is that that's probably not the case. And so some of the early studies did rely upon this expression, and now we're really much more focused on the KRAS mutation. And then again, just showing you, the reason I show this is that if, as you can see here, this RAS pathway, that if you've got something that is mutated and basically signaling in the opposite direction, that you cannot get growth inhibition with EGFR. So that it was really this, the component of the KRAS pathway that made us start thinking about perhaps patients that have that mutation would not respond to these drugs. And there's been a lot of presentations about this. There were, you know, if you look here, you can see on the left in terms of the weeks of progression-free survival, these numbers are much lower than the numbers over here. We started getting the sense that these drugs were really working best in the KRAS wild type patients. And this was another one where what was important in this study was using panitumumab to show versus just best supportive care. And the reason that was important was to give us a better sense for whether KRAS itself was prognostic, because we worried about maybe the KRAS mutation just telling us patients that weren't going to do well regardless. And so first of all, you can see here, again, we always like to see that curve doing better, that there was a better outcome in the patients that got panitumumab. And whenever you're comparing something to best supportive care, you can see, pretty dramatic results. And these curves basically told us, because these two curves look similar, that we did not feel that that KRAS mutation predicted that patients were going to do worse. It just told us that they weren't going to have a benefit to an EGFR antibody. Again, just showing that when you look at actual regressions of the tumor, that it occurred, tumor shrinkage really occurred in the patients with that wild type KRAS. And many of you have been probably tested for that. Hopefully everyone. And, the other interesting thing is that because this target is actually in your skin, then that's why you get the skin rash. So that skin rash is really reflecting much of what we expect to be happening in the tumor. And so one of the questions has been, if you have a worse skin rash, does that mean that you could potentially be having a better anti-tumor effect? And that's been interesting because there's been a suggestion that that may be the case. Now, I don't know that many of us would not still give it a try in the absence of a skin rash, but I think we always get concerned that maybe we're just not seeing the physiological effect of EGFR in a patient that doesn't get a skin rash. So really what we've learned here is that you can give the EGFR antibodies on their own. They probably are better at potentiating or improving the response to chemotherapy. And again, the biomarker results here, unlike what we do in lung cancer where we positively select patients, this is more of a negative selection. And I think for many of us it's frustrating because we would like to be able to then choose something for a KRAS mutant patient that conferred the same type of benefit. Again, we're really not seeing a lot in terms of benefit in the adjuvant setting. Again, this has been very confusing for us to sort out that. Many of us are trying to work on that. It's also very interesting what the contribution of the immune system is to the various antibodies and whether it also helps your immune system fight the cancer. And many of you have probably heard about some of the very interesting immunotherapy types of drugs that are in the process of being developed for colorectal cancer. And I think lastly, we just haven't seen the activity in the oral drugs that we've seen in the antibodies, and that's been a little bit surprising. This is just talking about this combination again. I think we would have loved to have seen that we could give combinations of targeted agents, even with the idea that potentially we could maybe have maintenance therapy after chemotherapy and basically not have to have patients on chemotherapy continuously. And unfortunately, what we showed was that, it was actually inferior outcome and certainly quite a bit of toxicity. Now, I don't think we're assuming that for all of them, but we think for VEGF and EGFR that that's probably the case. And this is a slide, if you didn't look at the paper, there's been a big sequencing effort in colorectal cancer, just making the point that clearly when you take the tumors from patients that have enrolled on clinical trials and do sort of what we call next generation sequencing, that we are coming up with a lot about the biology of colorectal cancer. And as you look at all these different pathways here, there's active drug development going just about in all of these. So I think, over the next few years, we'll see a lot more of this coming along. So I think in conclusion, and then I can take questions, we definitely feel encouraged that the biological targeting of EGFR and VEGF have really provided some clinical benefit in colorectal cancer, mainly in advanced disease. We haven't really seen that it's translated to adjuvant therapy, and we're trying to sort of work that out, going sort of almost from the bedside back to the bench. Biomarkers at this point are mainly useful for the EGFR agents, but I can tell you that many of us have ongoing sequencing efforts and are trying to link up the sequencing effort with how to select the best targeted drug. And really partly because we didn't see good results with sort of combining double biologics has really made us think, you know what, we've got to find out, the best drug for the best, for the patient. And when we get into combinations, we need to be thinking along a rational basis and not just sort of throwing things together. And I think that even though we've had these advances, I know you probably agree with this, this is really not enough. And so we've really got to move forward in preclinical and clinical research. And right now, a lot of that's going to depend on, I think, getting tissues from patients as they're coming onto a study so that we can understand why they respond or don't respond, and we need to really get better drugs into clinical trials. And I think that's the end, and I'll be happy to take questions.
Okay, great. Thank you so much, Dr. Eckhardt. And that's a beautiful picture of what I'm anticipating is your city of Boulder.
This is actually our campus in Aurora, Colorado.
Oh, wow. Very beautiful.
Yep.
So yes, we do have quite a few questions that have come in and that we've gotten actually prior to the webinar. So let me just jump in. So you talked about some different pathways and different drugs that respond differently to things. So is there actually, a question came in, is there testing that's actually available to determine which drugs will work best on which patients?
Yeah, that is a great question, and I think that so right now for colorectal cancer, really the main testing is revolving around the KRAS mutation. So and then we do look at the BRAF mutation. But in terms of what I think of as actionable, and when we say actionable, we mean have mutation, and now this helps us select a drug. And right now for colorectal cancer, it is not well worked out to do the sequencing and be able to make a decision. Now, it's very interesting why that is the case, because I actually run a phase 1 program where literally overnight we had all these mutations in lung cancer, we had these cool drugs, all of a sudden we could pick the right drug for the right patient, and colorectal cancer we think has some of those types of mutations, but it is not anywhere near at the level of lung cancer where we can go from sequencing to selection of a drug. So what's really going on now is people are trying to get the sequencing data and then either do clinical trials to test whether or not that strategy works, or go to preclinical models to see whether or not we can, at least before we go to the patient, see if that works. So it's really pretty early on. There's definitely centers all over the US where they will do the testing, and there are places where, like our place, if someone comes in and they have various components, then we can try to match the drug, but it's just not well worked out, to where I can say with confidence, like I could with a lung cancer patient. I know that's a long answer, but it's a very good question with a very complicated long answer.
So we're getting there, though, in colorectal. We're not quite there yet, but
yes, that's
getting there.
Yeah.
Okay. And then you talked a little bit about mutations. A question that came through is, what do you know that is effective to treat a stage 4 metastatic colorectal cancer patient who is KRAS wild type but has a BRAF mutation?
Yes. So the BRAF mutations, pretty soon there's going to be a lot of studies open. What we found is that we initially tried using the drug that we use in melanoma, vemurafenib, in colorectal cancer, and it really didn't work. And then some very sophisticated science was conducted showing that you actually needed to, for some reason, when you use vemurafenib in a BRAF mutant colon cancer, you get upregulation of the EGFR pathway. So it's almost counterintuitive, but the next trials are basically going to be targeting BRAF and EGFR. And the phase 1 trial is being done at MD Anderson. We've been on calls to where that's being developed into a national trial. So I think that there's going to be probably 2 or 3 other studies that really have that same idea, and that is combining a BRAF inhibitor plus another pathway inhibitor, because the idea is that that BRAF somehow upregulates a compensatory pathway, and so it'll be like a double whammy kind of approach. So I'm excited about that, and that's going to be something that we'll definitely want to get out to the community because you know, those mutations are more rare.
So this kind of leads directly into the next question, and that is about how patients can get involved in clinical trials. And I'm going to add a caveat here, and then I'm going to let you tell them your suggestions for it. But at Fight Colorectal Cancer, we do provide a matching service to kind of get people connected with clinical trials that they may or may not be eligible for, either in their local area or throughout the country. So if you want to go onto our website at fightcolorectalcancer.org, we have someone we can connect you with that will take your information and do kind of a search for you, or you can call into our answer line, which is listed there on the screen, and then I'm going to also let Dr. Eckhardt say what she suggests to her patients in terms of how you can find a clinical trial.
Yeah, so, you know, I always think this is a difficult question because at most academic centers you're going to sort of hear about what we have. I often refer people to the clinicaltrials.gov site. The problem is that you pull up a lot that way. So I think oftentimes it's useful if you're in an area where there's an academic center to contact them. Many times they will be aware of national trials and local trials. I think using advocacy organizations is a really great way to have more of a clearinghouse that's been somewhat vetted. So you know, it ends up being multiple sources, but certainly I think it's also important that your medical oncologist, you know, you sit down and, you know, listen about what's going on there, and then see whether or not there are trials that are maybe at centers that they're collaborating with, that may be in a city that's closer, that kind of thing. I wish we had a better way of sort of handing someone, you know, something that's relevant to their own case, and many times that's difficult. We can do that for the trials that we're running, but I think nationally it's difficult.
It's difficult, right?
But very important. So I think everybody has to work together on that.
Okay, let's see. So you talked about bevacizumab, which is Avastin, and you talked about Sept, which is Valtrap. Can you just kind of give a brief overview again of the differences between those two drugs, Avastin and Valtrap?
Yeah. So the difference with Sept is really, so they're both you know, antibody types of compounds, and Sept picks up another. So bevacizumab sort of gets out there like a sponge and sops up some of the growth factors, and Sept actually picks up a few more of the growth factors. So that's really the main difference. It's a little bit more of a bigger sponge, so to speak, versus bevacizumab. And that was really why it was developed, was the idea that it could be like a decoy or a sponge for more of the VEGF growth factors. And then, so that's sort of the biological part behind it. And then I think clinically, it's just really differences in side effects.
Okay, so if you're on either one of those, it's important to ask your physician about the side effects of either one of those.
Yeah.
Okay. Okay, so if someone wrote in about maintenance therapy, if someone's had chemotherapy and had 12 cycles of chemotherapy, why might someone need to continue on with maintenance therapy? I'm using air quotes, but why might someone need to continue on with something called maintenance therapy? Could you talk about that for a second?
Yeah, so this is one of the parts that has almost become like the art of oncology, and that is how to sequence the different drugs in colorectal cancer to get the most you can out of them, which oftentimes the first goal is to try to get someone to surgical resection if they have metastatic disease. And then what to do to try to maintain the best response but not induce resistance. So the reason why we get uncomfortable just stopping is that most of the studies have indicated that it's not the kind of disease where it's all that great just to completely stop. It's not like it's unsafe, but the data really supports that some type of therapy beyond best response is indicated, and that's so that's where that discussion comes up. We just haven't had evidence in this disease. Now, the good and the bad of it is that it is something that is more indolent than some other types of cancers, so that we can, take away the big guns chemotherapy and maintain with something less aggressive. But in terms of just totally discontinuing therapy in the face of metastatic disease, just hasn't shown to be of great benefit. So that's where those discussions come up.
Okay. All right.
It's a very important question, and most patients are going to get a slightly different answer and a different approach, from oncologist to oncologist.
Okay. So the next question is from a rectal cancer patient who, and I'm not quite sure if we talked about this tonight yet or not, about the difference between chemotherapy and targeted therapy. But this particular patient who has rectal cancer actually decided to decline chemotherapy and instead is just doing radiation, and now is wondering if these targeted therapies might actually work for them. What would be your suggestion?
Yeah, so chemotherapy right now, so for rectal cancer, it depends on whether it's metastatic or locally advanced, but with rectal cancer, we definitely use chemotherapy as adjuvant therapy and chemoradiation. And for rectal cancer that becomes metastatic, it's similar to colon, so we don't really treat it differently, but we definitely have a different treatment strategy that incorporates radiation and chemo. The biologics in rectal cancer really, at this point, haven't, someday they may become part of that adjuvant therapy, but as I said earlier, the targeted agents that have been tested so far have not shown a benefit in adjuvant therapy. For rectal, when it's metastatic, we pretty much feel the biology is very similar to colon. And what was interesting, even at the very basic level, is when they were doing the sequencing effort, they initially separated the colon from the rectum, the tissues. And as they started doing the sequencing, they found out that there was really no difference. So they pooled it all together. So the differences in rectal cancer have more to do with the anatomy of where it is that dictates the chemoradiation type of approach, but we actually think the biology is somewhat similar.
Oh, so the biology is similar in rectal cancer once it's metastasized.
Yes.
Okay.
Yeah, but it does have a different pattern of metastasis, oftentimes going to the lung more. Again, that's based on its anatomical location, not that it has different genetic components.
Okay. And let's see. So how, this is a little bit about side effects of drugs. How should a patient factor in the side effect profile of a drug in their decision for chemotherapy selection? Is that something that's very personal to them, or how do you have that side effect of each chemotherapy drug discussion with your patients?
Yeah, so it's extremely important. You know, I would say number one, you have to understand that many oncologists, when we talk about whether it's oxaliplatin like FOLFOX or whether it's FOLFIRI, irinotecan, as some of the initial approach to chemotherapy, there's many oncologists just have an inherent bias one way or the other. We don't at this point feel that either way is better. Some people are, so you're going to really, in your office appointment, you need to understand there's probably going to be an inherent bias there to begin with. But in terms of my approach is really trying to determine, for instance, if I'm going to, if neuropathy is existing already in a patient, maybe they have diabetic neuropathy, then I'm going to be very worried about the oxaliplatin right off the bat. On the other hand, if I have a patient that has a lot of bowel problems with diarrhea and discomfort, then I'm going to be more worried about irinotecan. But regardless, I always sort of go into it with the idea that these are regimens that really need to be livable. The patient needs to have the quality of life to do what they normally do. And sometimes people think that the goal is they're going to get this harsh therapy and sort of have a miserable existence, and that's somehow better, and it's not. So it's very important for people to understand that really the goal is very good control of the disease. We'd love to see people get converted to having a surgical resection. But at the end of the day, the side effects have to be managed aggressively so that quality of life is top notch. And that is the only concern I ever have sometimes when I see people coming from other places where maybe the doses weren't adjusted, because chemotherapy dosing is based on phase 1 trials that may have had all of 30 patients on the phase 1 trial. It was classic for irinotecan. When we did the phase 1s, the dose was too high when it went out into phase 2 and phase 3. So understanding that starting dose is really just that is really important. So there's, I think, many factors that come in to try to tailor that regimen to the patient in terms of side effects.
I think you gave some really good points there. So even before you start a chemotherapy regimen, tell your physician kind of what's important to you in terms of maintaining your quality of life. Absolutely. And then even once you've started that, if things aren't going well, sometimes patients feel like, well, it's chemotherapy, they expect to feel sick, and so they maybe don't bring up a lot of times how they're feeling or some side effects they're having, and it's important to do that because there might actually be another option.
Oh, totally.
For
Absolutely.
you. Okay, that's great. That's really good.
It's not like there's some breast cancer regimens, there's certainly some leukemia, lymphoma regimens where, the deal is you get 6 cycles, it's highly toxic, you're miserable, and then you're done. And that's really a different goal, and it's different types of treatment. This is quite different.
Okay, all right, that's good takeaways there. So some of the chemotherapies, or actually targeted therapies that you talked about tonight, the Stivarga and Zaltrap. So a question came in, do these new drugs, such as Stevarda or Zaltrap, prolong your life, or do they actually cure some people? I think this is a great question.
Yeah. So at this point, they are mainly prolonging life, and you saw some of the numbers. I mean, it's not real impressive, certainly not enough. Um, we don't, so chemotherapy or biological therapy, or targeted therapy, whatever you call it right now, in colorectal cancer, and actually for most adult solid tumors, we don't feel by itself is curative. So what we do with it is we either try to control, sometimes treat symptoms, and then certainly in colorectal cancer, if we're giving it in conjunction with chemo, then we're trying to really get a good enough response to potentially take someone to surgical resection in the liver.
Okay. Let's see. I'm just reading through a few. So you went over them tonight, but maybe if you could just recap, because the question had come in. The FDA approved therapies for colorectal cancer treatment. Unfortunately, there aren't many, but if you could just recap those for an attendee, that would be great.
Oh, the ones that are approved?
Yes.
Yes, so the historical one is 5-FU, and then shortly thereafter was irinotecan, and then oxaliplatin came along as really the next active chemotherapy. The oral form of 5-FU, which is capecitabine, which are pills, which many of you have probably had, and then panitumumab and cetuximab are the two EGFR antibodies. And then we have regorafenib, which is the oral VEGF targeted drug, and then aflibercept and bevacizumab. Now, interestingly, if you were to ever go search, there's sometimes you find other random drugs that are actually FDA approved, like I think mitomycin C is still out there. But the drugs on that one slide and that I just mentioned are the ones that we use.
Okay, great. Let's see. Can you talk just for a minute? We're going to go probably for another, I'm going to call it 7 to 9 minutes. If maybe we can get through the rest of these questions, if that's okay. Yeah. Can you talk just for a minute about the importance in colorectal cancer, if there is any, to be either have genomic or genetic? If you want to actually distinguish between those two things before you answer the question, that would be great. If that type of testing is helpful in patients with colorectal cancer.
Yeah, so I mean, we consider that the same, you know, genomics, genetics. The reason, you know, there's just a lot of omics going on now. So there's proteomics, genomics, all those things. So we think of that as really the same. So genetic testing, genomic testing. As I was saying, right now it's mainly used to determine whether there's that KRAS mutation. I think increasingly people are looking at BRAF. And certainly we have other genes that we're looking at, like PI3 kinase is something that you've probably heard about. The question about how important that is right now, other than the KRAS, we don't have a way to act upon it because we haven't found that X mutation, like PI3 kinase is a good example. In colorectal cancer, having that mutation and getting a PI3 kinase inhibitor is not a one-to-one, you know, benefit. Like lung cancer, where we have an ALK mutation, you get an ALK inhibitor and it generally works, or EGFR. So in colon cancer, I think it's important to have genetic testing done, and hopefully as part of a research program to actually start testing this, because right now the easy ones to look at are not leading us to the drugs. But it's a huge part of what we're doing and other people are doing, because we really want to make it that way. I mean, we want people to be able to get testing done and to tailor their therapy towards their genetics. It just turns out in colorectal cancer, it's not as simple as it was in lung cancer.
Wow, and that's a lot to consider for a colorectal cancer patient.
I wish I had a simple answer to that one. It is very complicated.
So this is another slightly complicated and perhaps anecdotal one that we would just maybe like your thoughts on. But somebody had written in a question that they had been on Avastin and they didn't have any rise in their blood pressure, and was on a combination of irinotecan and Avastin, and that kept them stable for over a year. And then used the combination of irinotecan and Valtrap after progression, and they did have a rise in their blood pressure with that combination. And so there was just a question put out there: does anybody look at any maybe type of correlation between rise in blood pressure and response to a drug? Does stuff like that get looked at or considered at all?
Yeah, so actually that's what we call a pharmacodynamic effect. So it's an effect of the drug when it's actually in the body, versus when we talk about predicted biomarkers like KRAS, you're basically predicting without the person ever having gotten the drug. So things like skin rash, high blood pressure with bevacizumab or aflibercept. Another one with those drugs would be protein in the urine, and that's just starting to be looked at. And it is something that I think would be very interesting if we could correlate some level of blood pressure effects with better effects. But we don't know that yet. It's definitely being looked at.
Okay, well, that's good news. So this is another very interesting one that just came in. Regarding failed clinical trials, were there some patients who actually responded to the drug? And if so, is there any effort to understand why they might have responded to a drug that actually failed in a clinical trial?
Yeah. Well, having been in drug development for 20 years, I mean, it's interesting because it's where a lot of people are talking about the quote N of one, which the N is the patient. And so, I mean, you can count on the fact that just because the trials were negative doesn't mean that no one had a benefit. And so the problem with the way studies used to be done is that we didn't have stuff like sequencing or information on the biology of the tumor when the patient had the response. And then, so we never learned anything, and we were never able to go and look for another patient that looked similar to that. So that's a huge effort nowadays. And that's part of why what we're trying to do is to make sure that when we run some of these early clinical trials like phase 1s and phase 2s, that what we would do is have that information. Because I can tell you in the phase 1 program right now, we have several patients that are on random drugs that have never made it to market. We've got 2 patients that have been on for 10 years that were given 6 months to live that responded. They're still on it, but they didn't ever have that sequencing done. Now the reality is that these drugs are kind of difficult ones to know, but that's really the idea going forward, is that every single patient that would have a benefit, whether they were on a failed drug or not, we would go learn about it and then be able to actually design a study potentially in a group that resembled that patient, and maybe turn a drug that didn't work for everyone into a successful drug for 5%.
Wow, very interesting. Very interesting. Another question that had come in is about our own immune systems. So could you just maybe talk for a second about the utilization of our immune system, maybe with some immunotherapies? How does that come into play for colorectal cancer patients, or does it not yet?
Yeah, so I think it's looking very good. It wasn't, all that useful until, I don't know why. I mean, there have been years of immunotherapy in colorectal cancer, but the new ones, which you probably heard of, which are the PD-L1s and anti-PD-1, which are sort of focused on the T cell component of the immune system, are looking very good. We've actually got a trial here in colorectal cancer where it's either given with bevacizumab or with FOLFOX, and we're getting really, really nice results. So, and you know, this is going on all over the country. So I fully expect that we're going to have, you know, launching of big trials of these types of immunotherapy in colorectal cancer. And it's really, really looking good. So I think that's a whole other area that is being pursued. And it may be, you know, one of those drugs will be one of the next ones approved.
Wow, that would be exciting. So we should stay tuned in the immunotherapy area. That's great.
It's really exciting, and I'm glad I have the trial because I get to see the patients having responses, and that's, you know, that's the most fulfilling thing, is when one patient I had got screened for a biomarker that we're thinking may predict for having a response, and is doing well, and you know, that's just, it's really wonderful.
Well, that's good. Maybe we could get some more information from you, and we can certainly let our constituents know about that.
Yep.
I'm going to try and squeeze 2 more questions in, if you don't mind. There is somebody with stage 4 colorectal cancer patient, or a stage 4 colorectal cancer patient, who is talking a little bit about pain control. And so this patient mentions the use of opioids. And their understanding is that opioids can be considered angiogenic promoting. And earlier you had talked about vascular angiogenesis drugs. And so, number one, is that true? And if so, how, as physicians, do you separate the effects from pain medication versus the therapy that the patient is getting?
Yeah, so that there actually is some very interesting research going on at a couple of cancer centers about this. So I sort of think about it as sort of a macro and a micro. So the microenvironment is that there are some very nice studies going on. The macro part of it, which is, do we have evidence from the studies that have been conducted where they've done retrospective studies, which is really all we have right now. You know, we don't have a lot of evidence for that. I mean, we don't have evidence for that, but I think it's it's something that there's groups that are working on that. I think, again, it's sort of a risk benefit, like what is the increment of risk versus what is the benefit from, you know, pain management. I don't think any of us feel that this is a major driver of angiogenesis, and certainly when we have patients that are on narcotics and we follow them over time, you know, we don't get a sense that this is driving their cancer progression. But it's scientifically, there are a couple of groups that are working on it, so I wouldn't want to just discount it out of hand. But I think until we have more data, we have to look at the risk benefit to the patient in terms of trying to have the best pain management and you know, not at this point just not having evidence that clinically that's relevant. But I think it's a very interesting question.
Yeah, having that evidence is just very important, certainly.
Oh, yeah.
And so I'm going to close it out with a question kind of underneath that same angiogenesis topic. It is about anti-angiogenic diets. Have you heard of these, and are they in any way effective?
I've heard of a lot of diets, but I haven't heard of that diet.
Okay.
Sorry.
That's okay. Very good. So I'm actually going to take advantage then and ask you one more question that you may or may or not have heard of. What about the effects of very high doses of IV vitamin C? Have you ever heard of that?
Yeah, I mean, I've heard of lots of different sort of high-dose vitamin regimens, and I mean, I think the caution is that most of the the vitamin studies that have been done so far have not, yielded a benefit. And so I don't think we have medical evidence for that. And that's, when I talk to my patients, I sort of always say there are many things that we don't have medical evidence to support or refute. And I think as a patient, people have to feel empowered. They're going to go out and make some choices about what they want to do about diet, about vitamins, about herbal supplements, many, many things that I, as a physician, can't really give them medical advice on, because my advice is really going to be based on evidence. But I totally understand that there are many unanswered questions out there. So I usually say, you really, some of these decisions you're going to have to make on your own based on the available evidence, and I can't really tell you, I don't have anything to go on. So I think that people, what I usually try to tell my patients is, during the times of treatment, we want to be very careful about drugs that are, herbals and other things that are going to interact with what we know is effective therapy. But there's probably a whole host of things out there that are safe, that may not affect treatment. And I think that's where patients sort of have to be empowered to make their own choices. I wish, as medical doctors, that we could help people make those choices, but we're often kind of stuck because the evidence isn't there.
Right, so you can't help them make the choices, but it's still important if the patient chooses to make a choice, that they discuss it with, or they at least tell you that this is what they're doing, so you can make sure there's no conflict with the treatment that they're getting from you.
Right, and I just try to have that be a partnership and a conversation, because if I don't have the data, it's not fair for me to say, oh, well, if you take that, I'm not going to treat you, or I don't believe in that, because the reality is that I really don't know,
Right.
And so I'm mainly trying to make sure that we are all on the same page with regards to the treatment, and it needs to be a partnership. And I think people have to feel empowered that they're going to go out and find out about things. And there are a few where I say these are absolutely ineffective and probably dangerous. But vitamins, there's some high dose vitamins that stick around forever in your fat, so you don't want those. But other things you just have to discuss, because it's really a partnership.
Okay, I think that's a really good takeaway to have. If we could all just be treated by you, Dr. Eckhardt.
Come on down.
So I just want to say, on behalf of everybody on the line tonight and everybody here at Sept Colorectal Cancer, I want to thank Dr. Gail Eckhardt for having someone with her expertise to provide this type of insight to the treatment of colon and rectal cancer is really, really terrific. And as I mentioned before, it will be archived on our website, so you can go back and revisit it if you missed anything. But a very sincere thank you to Dr. Eckhardt, to our VP of Operations on the line recording everything, and on behalf of myself and Sept Colorectal Cancer, thank you everyone for your time this evening, and be sure and tune into our webinar in October on the